Okay, so let's talk about left and right-sided heart failure. So right-sided heart failure, not as common as left, and left-sided heart failure can cause right-sided heart failure. So if we're looking at the right side of the heart here, we have our deoxygenated blood from the body going up into the pulmonary artery to the lungs. So either in the right ventricle with right-sided, there's either contraction or a filling problem. But either way, what happens is blood can back up into the superior vena cava or the inferior vena cava to our periphery. So we get peripheral edema, weight gain. We can also get an enlarged liver because remember our portal venous system is right here from our inferior vena cava. So we can get an enlarged liver, and then the patient can have signs and symptoms of liver failure. So on our left-sided heart failure here, we've got our oxygenated blood coming through our left ventricle and being pumped out to our body. It can be a contraction or filling problem also, and the blood can back up into our lungs, causing pulmonary symptoms. So this is when we would get fluid in our lungs or an increase of fluid in our lungs, crackles. Um, we would have to sit the patient up. They're typically sitting up to get that fluid to go down to the bottom of the lungs so they can catch their breath. So this is pulmonary problems. And then the increased pressure from left-sided heart failure through the system, through the body, can then cause right-sided heart failure. So like I said, left-sided heart failure is the most common. And so for this, because it is the most common, we're going to talk about left-sided diastolic dysfunction and then left-sided systolic dysfunction. So let's remember our diastolic is our resting and filling of the ventricle. And so in our left-sided diastolic, the ventricles have inadequate relaxation or might have some stiffening. So if the ventricle itself cannot relax and fill properly with blood, like a nice soft balloon, let's say, or it's stiffened or hardened from disease, then what we're going to have is an area in the ventricle that cannot properly give an adequate amount of blood into this ventricle that we need to be pumped out into our body to um, give us enough oxygenated blood. So it's not going to give us enough cardiac output when looking at our preload, afterload, and our contraction. So this is a system where there's too much. As you can see here, this muscle, the ventricle muscle, is hypertrophied, and it's probably some scar tissue. And so it's very, very stiff. And so the blood coming in here, there's just not enough room for it. And so it decreases our cardiac output. We usually don't look at the ejection fracture for our left-sided diastolic dysfunction. Well, we do, but it'll look almost normal. Because there's a small amount of blood in here. It's not a contraction issue, it's a filling issue. Whereas left-sided systolic is a contraction issue. So here you can see there's a nice area for that ventricle to fill. That's not the problem. This ventricle is nice and relaxed, not stiff, and so the blood can come in here ready to be pumped out to the body. However, in systolic is our contraction. The muscle in the ventricle is not strong enough to push the majority of this blood out into the aorta. It should be pushing out approximately 65% of the blood in the ventricle out to the body. Okay. What you'll see when an ejection fraction test is done, though, with this left-sided systolic dysfunction is it's going to be 40% or less. Now, I know the 40% and the 65, you might be thinking to yourself, well, that's really not that much difference, but it actually is. It- 40% is very bad. They are not getting enough cardiac output to sustain life usually. And sometimes you will get people with a 35%, which is very bad. Um, so this has to be corrected in order to get this ejection fraction higher, in order to get enough oxygenated blood around our body to perfuse our organs. So when our cardiac output does decrease from heart failure, there's a few items that few things our body does to compensate because it really wants to get that cardiac output up. So if we do have insufficient cardiac output to meet the demands of our body, the oxygen demands, then our organs and our brain will tell our body, hey, something is going on. I need you to help me out here because I'm not getting oxygenated enough. So these compensatory mechanisms will occur at the beginning of your body sensing that you're not being oxygenated, but it will only last for so long. It's kind of like giving you a boost so that you can kind of have time to go get help. Eventually, though, if these continue and you don't get the help that you need, then they will, in fact, damage your heart even more. So the sympathetic nervous system is activated, so it's going to increase our heart rate because it wants to give us more perfusion. By doing that, if we think of someone's heart rate being tachycardic at maybe 140, then it's going to fill the ventricle not as much as it normally does. So it's going to have a decreased filling rate of that ventricle, which means that when the contraction occurs, it is not pushing out enough blood because there's not very much blood in that ventricle before the contraction happens. So then that also increases your oxygen demand. So your lungs can become involved and you can have a high respiratory rate because your body is wanting you to get oxygen into your blood as much as you can. You're also going to have arterial vasoconstriction, so your blood pressure is going to go up because the body is trying to increase the blood pressure, increase the heart rate, and increase the oxygen in your body. When our kidneys see that there is a perfusion problem, then it activates the RAS system. And so that again is to increase the blood pressure. We have our sodium and water retention. And then the angiotensin II actually has this property where it does a ventricular remodeling. So now we're looking at the ventricle and it's going to remodel that to try and help, which it does initially, but then it starts to cause some ventricle problems in the long run because your ventricles do not want to be stimulated the way that the angiotensin II stimulates that area of the heart muscle. So also if we have decreased cerebral perfusion, so decreased perfusion, oxygen perfusion to the brain, then our posterior pituitary gland comes in and secretes vasopressin, so ADH. And that causes vasoconstriction and fluid retention. So all of these things, if you look back on the slides, increased heart rate, increased blood pressure, increased fluid retention, these are the problems that cause heart failure in the first place, or some of them anyway. And so the body is doing this because it needs to get that increased oxygen and perfusion. But if this is left too long, then it's also causing more problems in the future.